Hello, welcome everyone to today's multidisciplinary endocrine conference. We are very pleased to have one of our own, Dr. Swapna Dharashivkar Deo, to present today. Swapna joined the Endocrinology Fellowship Program here in 2011. She graduated from medical school from SETGS Medical College in Mumbai. She subsequently did her residency in internal medicine in Cincinnati and moved to Louisville, where she was working at Northern Community Medical Associates and later joined our group, our division as a fellow. After that, she has continued to be on the clinical faculty. She works in our clinics and excellent mentor for our fellows and residents in the clinic. She's also been active in giving talks every year. She has delivered one or two grand round lectures for our fellows and everyone who participates in these conferences. She has been active in research during her residency and fellowship, having won many awards for her presentations at the Endocrine Society and at ACE, and also during her residency at the American Federation of Medical Research. She is an excellent clinician, and today she will be talking to us about immunotherapy-induced endocrinopathies, which is a growing concern for many of us, since this is commonly used therapy now.
Good afternoon, everyone, and thank you all for being here for the grand rounds, both in person and online. The topic today, as you can see here, is the immunotherapy-induced endocrinopathies. We've been battling a little bit with the system here. Okay, so I have nothing to disclose. So starting off with the approval of immunotherapies for cancer therapeutic regimens, they have now become an integral and fundamental part of therapy. There's many different kinds of immunotherapies: immune checkpoint inhibitor therapies, immunomodulators, T-cell transfers, the cancer vaccines and such. We will be talking about specifically the immune checkpoint inhibitor therapies today. Immune checkpoint inhibitor therapies have received approval for a multitude of metastatic cancers and have shown a survival benefit. With every passing day, we have increasing approvals for this therapy. They've also been approved for adjuvant therapy and for maintenance therapy in cancers that have active cancers that have already been treated. As such, with the expansive indications and the increased use, we have also seen a myriad of adverse effects. So we're going to learn a little bit basically about what immune checkpoints mean, what are immune checkpoint inhibitors, recognize the endocrine adverse effects, and how to manage them. Let's start off with a case. A 68-year-old white woman was treated by oncology for a history of malignant melanoma arising from her vaginal area. She had undergone surgical resection and then was started on a combination immunotherapy with immune checkpoint inhibitors, ipilimumab and nivolumab, in October of 2021. Just after the second dose of immunotherapy, she had severe diarrhea and was started by the oncology team with the steroid dose pack. Had no improvement with the diarrhea and was given another dose pack of steroids. This was followed by a high-dose prednisone regimen of 60 milligrams for 10 days and 50 milligrams for another 10 days. At the end of the regimen, she complained of some dizziness, blurred vision, multiple falls, and had a syncopal event. The steroids were tapered down, which she stated it seemed to actually help her then. However, most of this happened around November or so. A month later, in December, she presented to her routine oncology appointment. She reported being very tired had onset of headaches and had an MRI done for it, which showed abnormalities suspicious for metastases. The oncology team suspected metastatic melanoma to the brain, and radiotherapy was planned, but she was referred directly right from the oncology office to the endocrinology department for a stat evaluation. On exam, she appeared to be very pale and tired appearing woman in wheelchair, could barely get her words out, but her vitals were normal with a normal blood pressure of 112/60, pulse of 75, and O2 SAS that were 98%. No other obvious physical abnormality was noted. So these were her labs on initial presentation over the months and the day of presentation. So she did have a normal sodium of 137. However, the day she presented, it was down to 132, hyponatremic. Had serial ACTH levels done with concomitant cortisol levels, which were perfectly normal at baseline, but seemed to be dwindling down with a low of 3.2. There was no ACTH done here. The thyroid numbers, which were normal, were initially hyperthyroid, with a month later becoming hypothyroid, and then a low TSH with low free T4 presentation. These were the labs post-therapy, so we'll come to that later. The MRI reading was as below. The pituitary gland is enlarged with a convex upper border. It was also homogeneously enhancing, which was new from the comparison, which is kind of important. The comparative MRIs are an important aspect of this. No associated T1 hyperintensity was seen. There was no hemorrhage. And they suspected, because of the rapid interval enlargement, this is concerning for metastases. So this is what the MRI pituitary looked like in September. This was pre-therapy with the immunotherapy agents. And this was post. As you can see, it's got a more globular presentation with upper convex water and enlargement. All right, so what are immune checkpoints? These are molecules that are expressed on immune cells, and they are important for immune homeostasis and immune function. These can be both inhibitory and stimulatory. So the inhibitory immune checkpoints are predominantly the Ctl4, which is the cytotoxic T lymphocyte-associated antigen 4, and the programmed death antigen, which is a PD1, along with additional molecules, which are the LAC3, TIM, and B and T lymphocyte-associated, the BTLA antigens. Or they could be stimulatory, which is the CD28, the ICOS, or the inducible T cell co-stimulator, CD137, OX40, and CD27. So we'll be talking a little bit more about both the inhibitory and stimulatory. So just try to remember the CTLA4, PD1, and the CD8 for our future slides. The immune checkpoint, CTLA4 and programmed death1, are essential mediators of T cell function because of the inhibitory action. The CTLA4 mediated cell inhibition is predominantly localized to the lymphoid organs, whereas the PD1 axis dampens the T cell response in the peripheral non-lymphoid tissue, including the tumor microenvironment. The CTLA4 is a key receptor that is expressed on the surface of T lymphocytes, but it may not always be on the surface. Sometimes it's it's intracellular, and it might be trafficked to the cell membrane on activation of the T cells when the need arises for T cell inhibition. The PD1 is expressed by the activated T cells, B cells, the natural killer cells, and some myeloid subsets. The PD ligands, the PD ligands 1 and 2 engage the PD1, which basically activates it. And these, the ligands are found predominantly in the macrophages, the dendritic cells, cancer cells. So the tumor actually has those PD1 ligands, as well as in the damaged tissues. So CTLA4, what it does is it inhibits the T cell receptor activation, and it does that by binding to its ligand B7, 1, and 2, which are also CD80 and 86, a different terminology, which causes a downregulation of the T cell activation. As we'll see in the future slide, these same ligands are actually shared by the stimulatory checkpoint CD28 as well. But because the CTLA4 has increased affinity to these ligands, it does not allow these ligands to bind with the CD28, which is a co-stimulatory mechanism, and prevents the activation of the T cells by binding to these ligands. The PD-1 ligands are regulated by the cytokine stimulation, so they're kind of predominantly active in the inflammatory settings. And the engagement between the PD-1 by the PD ligands causes the dephosphorylation and other intracellular processes, which causes disabling of the T cell function by inhibiting the co-stimulatory CD28 signaling. We'll come to this slide in just a second. So what is CTLA4? It is a glycoprotein, and it actually shares the same family as CD28. So here you have CTLA4, which is an inhibitory molecule, whereas the CD28 is co-stimulatory. They both share their ligands, CD80 and CD86, which is the B7, 1, and 2, but CD28, with the CD28, but it actually has an inhibitory effect due to the binding affinity and not making those ligands available to the CD28 for its own action. The CTLA4 is also expressed on the regulatory T cells, and like I said, at a baseline, it's present intracellularly on the T cells, but has the ability to be trafficked to the cell surface on activation. And they inhibit the T cell activation by both multiple intrinsic and extrinsic mechanisms, which we won't go in right now. And also the conventional T cell activity, it inhibits that by signaling through the regulatory T cells. The program DEath1 belongs to the CD28 family, but does not share the ligands with the CD28. It has its own specific ligands, which are the L1 and L2. The PD1, like I mentioned before, is expressed on these T cells, B cells, and their surface expression is low, but is increased when the T cell gets activated. It almost is like it regulates itself. When the T cell gets activated, it also expresses more of the PD1 so that it is not an uncontrolled activation. So there's some inhibitory signaling. Engagement of the PD1 by ligands during the T cell receptor signaling can block the T cell proliferation and the cytokine production and impair the T cell survival. It also inhibits several of the intracellular signaling pathways. So the tumor cells actually express the PD-L1, and it uses that as a mechanism by which they escape the detection by the host immune system. So going back to this little diagram here, okay, so this is the tumor microenvironment. Not sure that you can see very clearly, but it's just to show you how it all works. So the tumor microenvironment will present its antigen on the antigen presenting cell to the T cell through the MHC, the histocompatibility complex, and causes the activation of the T cell. But you have the engagement of the PD-L1 and the PD-1, which is also expressed by the antigen presenting cell, which in turn causes the inhibition. So the reason the tumor cells proliferate is because they have a lot of this inhibitory activity on the T cells, which prevents its own ability to be activated and attack these tumor cells. So what we have is these antibodies which bind to the ligands or to the PD-1 receptors, which prevents their engagement so that the T cells can be activated, as you can see in this diagram. So you have these anti-PD-L1 antibodies which attach to the PD-L1 ligands, and then the anti-PD-1 antibodies which attach to the PD-1, and basically the T cells can now get activated because of the lack of their suppressive effects. Similarly, here in the lymph node, here you also have, so here's, this is the site for the CTLA4 action. And here as well, you have the B7, which is the ligand for, or the CD80 and 86 ligands that attach to the CD28 and cause a co-stimulatory signal, which causes the T cell activation. However, because the CTLA4 has increased affinity to this very same ligand, the ligand is no longer available to the CD28 for its activation, and now you have a T cell inhibition. Here comes the role of your checkpoint inhibitor, which will attach to the CTLA4. So the CTLA4 antibodies will attach to the CTLA4 immune checkpoint and basically make it not available to cause all the effects that it's doing so that the activation can go unsuppressed. So what are the inhibitors? Again, like I already said, these are monoclonal antibodies that target the CTLA4 and PD-1, which results in T cell activation by the mechanisms we just now discussed. They increase the T cell activity, and they do it by several mechanisms, which includes production of the immunomodulatory factors, such as cytokines, which play a role in both the initiation and persistence of the anti-tumor immunity, and potentially they increase the activity of the T cells. While they're doing all this, since they are now activated, they also attack the body's own immune system, and that's where all the immune-related adverse effects occur. So here's a list of some of the common immune checkpoint inhibitors related to the CTLA4. Ipilimumab is the most commonly used therapy for a lot of cancer therapies. Tremelimumab is not, it's got an orphan drug status and is used for, I think, mesothelioma, but it's really not used in mainstream. PD-1 immune checkpoint inhibitors are pembrolizumab and nivolumab, which are the most common ones that we'll talk about today. And then the PD-L1 immune checkpoint inhibitors are atezolizumab, avelumab, and durvalumab, which we'll talk a little bit about. Here's a list of the cancers treated with immune checkpoint inhibitor therapies. This is by no means exhaustive. I just wanted to give you a list. There are multiple cancers that are treated, and as such, the use has expanded over the years. So what are immune-related adverse effects? So while these immune therapies are targeting the tumor antigens, they also inadvertently, or sometimes because of cross-reactivity with these antigens, they might attack the body's normal systems and organs as well. So the immune-related adverse effects involve the skin, colon, liver, lungs, and endocrine organs, and less commonly kidneys, eyes, nervous, cardiovascular, pretty much every other system, though in a minority. Endocrine adverse effects would probably be one of the most common adverse effects, along with skin and gastrointestinal. As we noted in that first patient of ours, or in that patient that we discussed, the diarrhea was probably the first adverse effect that manifested as colitis or gastrointestinal adverse effect. So the CTCAE is a common terminology criteria for adverse effects that grades these adverse effects according to the severity. Grade 5 is the most severe, which is basically death. Grade 1 and 2 are mild, whereas 3 and 4 are more severe. We're not going through the details of these, but you can use these to categorize your patients into grade 1 or 2, which usually the management is a little bit less intense in grade 1 and 2 versus grade 3 and 4. So this is just a graph showing the timing pattern of endocrine side effects related to these three commonly used agents. Ipilimumab adverse effects probably occur the first, and as you can see, they are usually permanent. And we'll see why subsequently. The nivolumab and pembrolizumab adverse effects occur around the same time, a little bit later than the ipilimumab, but it seems like nivolumab might regress to normalcy. The side effects might improve, adverse effects might improve earlier than the pembrolizumab. So a few things about the ipilimumab immune-related endocrine adverse effects. These are dose-dependent. So the frequency and the severity of the adverse effects are higher for the less than 3 or 3 milligram per kilo dose versus the higher doses. They have been reported in about almost a third of the patients. Hypophosis is probably the most frequent. It's grade 3 to 4, so we know it's pretty severe, and a dose-limiting endocrine adverse effect, and distinctive of ipilimumab, because it's probably the single most important agent that causes hypophosis as a side effect. The hypothyroidism and hyperthyroidism are next in frequency. They occur in a well-defined characteristic timing pattern where they're typically expected to appear about the 6th or 7th week, but the onset could be as late as 20 weeks. The endocrinopathies are not resolved because the function of the gland is often permanently damaged, mostly because of a destructive process. The PD-1 related adverse effects, usually thyroid dysfunction is the most common, with the incidence of both these agents being almost similar. The hypothyroidism occurs in about 9%, with a median time to onset being 3 months, and a resolution in a third of patients. In pembrolizumab, in this one particular study, it was shown to be 7 to 9% as well, mainly again grade 2, with the onset 3.5 months. Like we saw, there was just a small difference between nivolumab and pembrolizumab in their onset, and result in about 20% of patients. There's a lot fewer side effects associated with the ligand inhibitors, about 6 to 10%. The combination therapies, though, cause a much higher incidence of side effects. This increased incidence of endocrinopathies, about 14 to 50%, with thyroid adverse effects being the most frequent, up to 28%, hypophysitis being up to 12.8%, with grade 3 to 4, so the severe adverse effects occurring about a fifth of the cases. The pembrolizumab and ipilimumab has been associated with endocrine adverse effects in 28% of patients treated, with thyroid gland being the most affected, mostly hypothyroid. This is just a quick chart to show you about the monoclonal antibodies and all the side effects it causes. You definitely don't need to focus on everything. I'll go over the percentages in certain conditions. So hypophysitis, you see in all of these, ipilimumab has the highest percentage. If you go down this row, there's basically no type 1 diabetes in CTLA4 related agents. In the anti-PD-1, there's an increased incidence of thyroid disorders, hypo more than hyper. And same with your ligand inhibitors, where you have the thyroid effects more common. But here you definitely see the type 1 diabetes and primary adrenal insufficiencies show up. In your combined therapies, the nivolumab and ipilimumab seems to cause the highest number of side effects, about 12.8% hypophysitis, and a good number of patients getting hypo and hyperthyroidism. Again, not many, if any, at all, type 1 diabetes were noted with these combo therapies. So this is a very good graph showing the incidence of thyroid function and hypophysitis, since these are the two major adverse effects associated with these therapies, with mono and combination therapies. So let's just directly go to the combo therapy, which is the blue. You can see that in all of these conditions, hypothyroidism, hyperthyroidism, and hypophysitis, the combo therapy causes the most likelihood or higher incidence of side effect. Hypothyroidism is the highest with the combo, and hypophysitis is lower down. But if you talk about monotherapies, which is the ipilimumab in the anti-CTLA4, your hypophysitis is almost predominantly caused by ipilimumab versus PD-1 or PD-L1 therapies, anti-PD-L1 or PD-1 therapies. And then your other graphs, basically, your green is the anti-PD-1, which is the pembrolizumab, and the nivolumab, which causes a higher incidence of hypothyroidism in monotherapies. We're not taking into consideration the blue bar anymore, and same here as well. So what is immune checkpoint inhibitor-related hypophysitis? So fasciitis, like anything, is inflammation of the pituitary gland. It is most commonly associated with the ipilimumab and greatest with the combo therapy. The most common dysfunction is the anterior pituitary dysfunction. You almost never see diabetes insipidus or pituitary dysfunction with these therapies. So it causes central adrenal insufficiency and central hypothyroidism, the higher incidence in men versus women, and elderly are more likely to be affected. The most common presenting symptom is headache and fatigue, which is kind of non-specific considering most of the cancer patients are probably fatigued anyways. So it's very important to be vigilant about worsening fatigue or new onset fatigue associated with a headache. And pituitary MRI is needed for diagnosis. What's the differential diagnosis? Well, brain metastases. The interesting fact about brain metastases is that they usually occur in the posterior lobe in about 70 to 80% of the cases. So the presenting symptom is actually DI. So if you have a patient who's having DI symptoms, you probably want to suspect a MET more than a hypophysitis scenario. Biopsy is basically never ever done in hypophysitis related to immune checkpoint inhibitor therapies. So that's never the treatment, management route. So it's only indicated if you suspect a pituitary mets and the posterior pituitary symptoms. What is the pathophysiology of ICP-related hypophysitis? Well, a lot of this is still being studied, but there are some things that are the likely causes, which is the activation of the antibody-mediated cell toxicity, cellular humoral responses, complement pathway activation, and then there's some thought that the CTLA4 is actually expressed in the pituitary glands, which makes them a target for attack, which causes the hypophysitis. The IgG subclass specificity is more, but these two agents, the durvalumab and atezolizumab, have some molecular configurations that, even though they are in that IgG1 subclass, they really don't have that same molecular configuration, which causes them to cause these hypophysitis side effects. We don't know if there's a role of anti-pituitary antibodies in this situation, and pathology, because we don't biopsy, is not exactly known. So like mentioned before, the clinical manifestations, headache and fatigue are most common, and then a host of other non-specific symptoms, which includes nausea, decreased appetite, dizziness, decreased libido because it can cause hypogonadism as well, cold intolerance because of your hypothyroidism, hot flashes, weight loss, so a whole lot of different things. Usually the enlargement is not very significant enough to cause optic chiasmal compression or so, so mass effects, visual disturbances are usually not seen. The symptoms present within 2 to 3 months of ipilimumab initiation and can occur as long as 19 months later. Something, again, to note that our patient had some manifestations in December, about 2 to 3 months after she started her therapy. Central hypothyroidism, low or low normal free T4, and these are just regular definitions, and so I won't be going into detail, but they can be, because of the changing scenario and the rapidly changing labs, they can mimic other situations as well, including non-thyroidal illness syndrome. And then you have your central adrenal insufficiency, which is usually manifested as hypotension, hyponatremia, dehydration, and you might need an ACTH stim test, but not before treating the patient emergently if needed. Hypogonadotropic hypogonadism with low LH-FSH and low estradiol and testosterone might be seen as well. So imaging characteristics, again, pituitary enlargement, mild to moderate, not very big, some stalk thickening, no impingement of the optic chiasm. It could be homogeneous or heterogeneous. Enlargement actually may precede your clinical diagnosis by weeks, and sometimes may have actually resolved by the time you actually make a biochemical diagnosis. So comparative imaging is important. Comparing it to your prior MRI, if available, is always a good thing. It usually resolves within weeks to months, and normal imaging does not rule out the diagnosis. So this is a nice representation of the process in endocrine review. So in this first diagram here, you see the normal pre-treatment pituitary, and then this enlargement with some convexity of the upper water, and then resolution later. Another diagram that shows the enlargement of the pituitary right there. So how do you manage? Well, pre-treatment counseling is really important, where the patients need to be made aware that these therapies are likely to cause these side effects, so that if they have any new symptoms, they're more akin to letting you know, but also they don't have this diagnosis sprung upon them all of a sudden. Monitoring is important, and there's a few differing time frames in the guidelines. We don't have any specific endocrine society guidelines per se, but the French Society does have its guidelines for this endocrinopathy. But in general, TSH and free T4 to be checked prior to and at every treatment visit for the first 5 cycles. Adrenal axis to be checked again prior to treatment and before each dose. And same with the gonadal axis. Now, the growth hormone axis, they do ask you to check the IGF-1, but the utility is really limited, and you definitely probably don't want to do that on a repetitive basis because most of these patients, you're not going, or any of these patients, you're not going to treat with growth hormone with the ongoing cancer diagnosis. Also, with low testosterone and estradiol, these therapies also have to be initiated taking into account all other contraindications and indications in that patient. The prolactin is almost always low. So the management of ICP inhibitor, the immune checkpoint inhibitor-related hypophysitis, it's just a little bit tricky with the adrenal axis. In general, you do not want to use high-dose steroids for treatment because there has been no proven benefit with the high-dose steroids. However, this was one of the older papers as well, but also if there is significant clinical deterioration, which includes adrenal crisis or so, you might want to start high-dose therapy with these doses, the methylprednisolone 1 to 2 milligrams per kg IV, followed by oral prednisone 1 to 2 milligrams per kilo, or dexamethasone as was reported in this particular JCM article. Once hypophysitis resolves, you can go down to your usual replacement doses. And then again, the drug should be held if you have severe cases. Normally, though, replacement doses for those not critically ill are usually sufficient in 15 to 20 milligram hydrocortisone in divided doses. The replacement done after the replacement has to be done for the thyroid after you have replaced the steroid because you don't want to precipitate adrenal crisis. And the gonadal axis hormone replacement therapy is done considering all usual contraindications. Now, for the adrenal axis, in somebody who looks ill but not severely ill, one paper also recommends doing 2 to 3 times the replacement doses, about 60 milligrams to dose for about a week before reassessing and then tapering the dose. The hyponatremia, if present, usually resolves after appropriate corticosteroid and thyroid hormone replacement, but if it persists, then you probably want to look for other causes for excessive ADH secretion, including lung mets or cancers. This is for the same stuff that I just told you about. Patients may continue the immune checkpoint inhibitor therapy, although it is reasonable to delay resuming until the symptoms resolve. So prognosis, recovery is rare, as you saw that first graph from the ipilimumab, especially for the central adrenal insufficiency. But you might see recovery from central hypothyroidism and central hypogonadism, which takes about 10 to 15. I did want to mention that the ipilimumab package insert wants you to withhold therapy in the event of symptomatic endocrinopathy and resume it once you have resolution of the adverse reactions or it's at a lower grade, and those who are receiving less than 7.5 milligram prednisone or its equivalent. For those with symptomatic reactions lasting 6 weeks or longer, you probably want to continue it completely, permanently. So the immune checkpoint-related thyroid dysfunction. So you have your thyroid dysfunction from your hypophysitis, which is the central, but you can also have primary hypothyroidism due to destructive thyroiditis, and it's one of the most common endocrinopathies. You could have Paratoxicosis, which is not as common as your hypothyroidism, which could be both overt and subclinical. And you should determine if it's primary or secondary, but if you do suspect secondary, then your suspicion for hypophysitis and evaluation for that should go up higher. So it's most common in the combo therapy with ipilimumab and nivolumab, followed by the anti-PD-1 therapies. Hyperthyroidism is more common in this combination, and the time onset could be as short as 7 days and as less as 1 dose. Graves can occur, and orbitopathy can occur, but they're both pretty rare. Sorry about the typo there. So what's the role of autoantibodies? We don't really know whether they play a causal role or increase the risk of development. So though some papers do agree that elevated baseline antibody levels may be a risk factor. Development of antibodies after the initiation of therapy does not guarantee the development of thyroid dysfunction. And as such, we don't really need to be checking antibodies at a regular interval. The thyroid function should be good enough. Management, back again to the same thing. You should be able to distinguish between primary and secondary, because if you suspect central, then you should proceed with the hypophysitis evaluation. The treatment doses are usually lower, so 0.8 micrograms per kilo to start off with, because a lot of times these are not permanent and they might resolve. Some of these patients might be elderly, they might have cardiac issues, so they might even need lower doses, 25 to 50, but if needed, they can be titrated up to the usual dose of 1.6 to 1.7 micrograms per kilo. Paratoxicosis, if present, is usually just treated supportively with beta blockers, because again, it might be self-limiting. Anti-thyroid drugs are rarely used unless you suspect cases of Graves', and high-dose steroids are not routinely used unless, again, you have some severe cases of Graves' orbitopathy. So should be monitoring labs every 2 to 3 weeks. ICP therapy can be continued as long as proper monitoring and treatment is started. So going to the diabetes mellitus, the hypophysitis and thyroid are the usual common side effects, but diabetes mellitus can also occur. It is rare, but could be potentially life-threatening because sometimes the presentation might just be diabetic ketoacidosis. Most cases occur due to the anti-PD-1 or anti-PD-L1 therapies, so your nivolumab, pembrolizumab, or the 3 agents in the anti-PD-L1, but majority on the PD-1. Ctl4 therapy is usually not a cause of your diabetes. The median age is in the 60s. It can occur after a single dose, or it could be as long as after 17 doses, and high risk of diabetic ketoacidosis because there is an endogenous insulin deficiency. What are the characteristics? There's very rapid onset of hyperglycemia, which means that the A1C hasn't had time to increase yet. Your A1Cs could be in the median range of 7.6, but your glucose could be as high as in the 500 to 600 range. There's a swift progression of insulin deficiency because of a destructive process and high risk of DKA. And the presenting symptoms, like usual, could be polyuria, polydipsia, and fatigue, but also abdominal pain and nausea. So this is a really nice graph about days before diabetes diagnosis. You can see the steep increase in your blood sugars going up to as high as 600 within a short frame of time, just 10 days. You know, it was all down here, and within a few days it went up. So it's somewhat similar to fulminant type 1 diabetes, where your fulminant type 1 diabetes is characterized by occurrence of decay as well. Within about 7 days after onset of hyperglycemic symptoms, plasma glucoses are high in the 288 or more range, with A1Cs around 8.7, and the urinary C-peptide excretion is low, with a fasting C-peptide and a stimulated C-peptide being low as well, less than 0.3 and less than 0.5. However, there are some differences. Islet autoantibodies are generally undetectable in fulminant type 1 diabetes. They're found in about 50% of your immune checkpoint related diabetes. There's usually an elevation of your pancreatic enzyme levels in your fulminant diabetes, but not in the ICP-1, ICP inhibitor related diabetes, and the flu-like symptoms are commonly reported in your fulminant type 1, but not in the ICP inhibitor-related DM. What is the pathophysiology? Well, maybe autoimmune antibodies. Dilated autoantibodies might be present prior to, or they might occur after initiation of therapy. But we don't know if this antibody testing is useful for monitoring. But we do know that the HLA class 2 genes in the histocompatibility complex and confer the strongest genetic risk for type 1 chromosome 6p21. And the polymorphisms, we don't know if there's any role. We really didn't go into polymorphisms much, but we don't know if they have any role. It's not been studied. So management is just like any other diabetic ketoacidosis management. However, counseling prior to onset is very important. Watch for signs and symptoms, and start insulin therapy as soon as you suspect it, because this is going to be a long-term need with basal bolus insulin therapy. And they might need inpatient management. The immune checkpoint inhibitors can be continued as long as the diabetes is treated and there's no role for steroids. Adrenal insufficiency, primary, is a rare side effect. We do know that central occurs in your hypophysitis, but the primary adrenal insufficiency can occur as well with the ipilimumab, nivolumab, and pembrolizumab therapies. They must be distinguished from your central because, again, you want to be evaluating for hypophysitis or metastases in case you're suspecting central adrenal insufficiency. Primary adrenal insufficiency in these cancer patients can also be because of mets to your adrenal glands, because of bilateral adrenal hemorrhage, or other infective conditions as well. We don't exactly know the pathophysiology of this and the role of adrenal antibodies. So it is characterized by low or relatively low cortisol level in the setting of elevated pH, which is the usual definition of primary adrenal insufficiency. No response to cosentropin. The aldosterone levels tend to be low, and it's important to assess for mineralocorticoid deficiency because of the need for replacement in addition to the glucocorticoids. Your manifestations, again, are pretty similar: fatigue, dizziness, hypotension, anorexia, weight loss, abdominal pain. They might present with adrenal crisis, which could be life-threatening or fatal. Hyponatremia, hyperkalemia is common. The imaging may show adrenalitis, inflammation. You need to be checking your ACTH, cortisol, renin, and aldosterone with an ACTH stim test. You can also check your aldosterone after the ACTH stim test, which if it's less than 5 nanograms per deciliter, it indicates primary adrenal insufficiency. And it's helpful to distinguish when you have a lot of overlapping symptoms and need to figure out if the patient has a primary versus a central component. I don't know how useful the antibodies, adrenal antibodies are. Nice picture of your adrenal glands, 2 views. Here's your normal adrenal gland here, and then the inflamed adrenalitis picture. Treatment. Just steroids if you have adrenal crisis or severe illness, which is 100 milligrams IV followed by 50 every 6 hours to be tapered as soon as they start improving, and replacement doses if it's not a severe case. So 15 to 25 milligrams of hydrocortisone in divided doses along with 0.1 milligram or 100 micrograms of fludrocortisone. This is a chart to just quickly review everything that we just said. I probably will just run through this. You need your baseline testing with all your pituitary labs. Again, the role of IGF-1, checking it, I'm not so sure. Got to check for your clinical features prior to each cycle. If you do have something suspicious, if there's visual symptoms, mass effect, you want to go ahead and get that MRI and your endocrine evaluation. Screen your labs with each cycle or every other cycle at least. If they're similar and everything's going well, you can continue just monitoring without a lot of biochemical testing. But if these are abnormal, your pituitary imaging, this is more for the oncologist. They want the oncologist to refer to the endocrinologist for further workup. And if hypophysitis, thyroiditis, or adrenalitis is confirmed, then you have to be grading it between 1, 2, which is the lesser of the severe ones, versus 3, 4, and manage accordingly. If you have mass effect, you stop the immunotherapy, you give hydrosteroids and replace your hormones. If it's grade 1 or 2, you could continue the immunotherapy and do your hormone replacement in physiological doses. And with grade 3, you delay your immunotherapy. You could restart it later, but for now, delay, get your hormones replenished and follow up. And then you might want, in this situation, to consider the hydrosteroids. If it's grade 4, you stop the immunotherapy and you do your steroids and hormone replacement. So are the adverse effects all bad, or does it actually mean something good? Well, because it's the same process by which your body is attacking the tumor antigens and getting a positive response or better survival benefits, we think, and several studies have suggested, a positive association between the development of immune-related adverse effects and the improvement in tumor response. And the survival likely due to enhanced ability of the immune system to recognize and destroy cancer, because now they are more immunologically active. So while they're attacking the cancer, they're also attacking your body's organs, and you're seeing the adverse effects, but it means that it's taking care of the cancer as well. So in a few of these studies, the Icp-related, inhibitor-related thyroid function, they compared those and survival outcomes in the non-small cell lung cancer with pembrolizumab, and found that the median survival was longer, about 40 months, in those who developed thyroid dysfunction versus those who didn't. And in another paper, the median survival in patients who developed ipilimumab hypophysitis was 19.4 months versus 8.8 months. So maybe it's not all that bad at all if you can recognize it, treat it appropriately, and be able to continue your immunotherapeutic regimen. So going back to our case. So this patient had normal baseline labs, had therapy with the nivolumab and ipilimumab, which caused initial phase of actually thyrotoxicosis. I don't think anything was done at this time. Labs were drawn. She had a follow-up lab, which showed resolution of this hyperthyroidism, and now she had primary hypothyroidism. Again, when she presented to me here, which was another 3 weeks later, she was still not on any thyroid replacement therapy. Now she appears to have a superimposed, or maybe just a separate, central hypothyroidism, where now you see that the TSH is inappropriately normal with a very low free T4. But you're also seeing these other things, which includes the hyponatremia and the low cortisol, which led me to believe that she now had hypophysitis. What helped further was the fact that she had a headache, she was weak, came in a wheelchair. Her vitals were normal, thankfully. But she also had an MRI, which showed that she had enlargement of the pituitary with this upper convex border, which would have gone with the hypophysitis diagnosis. She was started, so actually did not end up admitting her because of her normal vitals, but I did end up giving her not just replacement and not really high dose, but in between 3 times the replacement doses, so about 100 milligrams of hydrocortisone in divided doses, and started her on levothyroxine, told her to start the levothyroxine therapy after she had at least 3 doses of the hydrocortisone in. So steroid replacement followed by the levothyroxine, which was started about at 0.8 microgram per kilo, so around 50, I think around 50 or 75 micrograms. I did try to call her almost every day over the weekend. She had significant improvement with her symptoms, and she presented to oncology a week later, I think, And at that time, I had already, so here again, this is basically the situation with oncologists and endocrinologists need to be in close touch with each other. So thankfully, the oncologist had already, by sending the patient to us, he had already taken the first step. And I was able to talk with the radiation oncologist about considering a repeat MRI, or at least just waiting before considering radiation therapy for the presumed metastases. So a repeat MRI was done at 2 weeks, which showed some improvement, not complete resolution, but some improvement of the pituitary gland, enough for them to not do the RT. And the patient came in for a follow-up, walking, no longer needing the wheelchair, feeling significantly better. He was tapered on the hydrocortisone, though not to physiological doses, still at higher than required doses, but felt significantly better at every subsequent follow-up. The ipilimumab was stopped, but she was continued on the other therapy, and I'm not sure if they're planning on resuming it since she's doing better. So, in conclusion, checkpoint inhibitor therapies induced endocrinopathies can be long-lasting. They cause significant morbidity. They have no known predictive biomarkers, often have overlapping symptoms with the cancer itself: fatigue, headache, nausea. Suspicion and timely diagnosis, treatment, and monitoring are extremely important, and absolutely need the team approach with the oncologist and endocrinologist. Thank you. And I think I can get to the chat window now if anybody has questions.
How often does more than one?
I would say with the combination therapy pretty often, especially your hypophosis and thyroid.
What about adrenal?
I don't have the exact numbers, but in general, adrenal is rare. But the sporadic cases mentioned in all these multiple reports, so usually it's just one case and kind of discussion about those cases, but they do occur. I mean, it's not that uncommon to have multiple organs affected. I think I have Mr. Kotwal's question. I can't say I know that. I would presume, so the question is, Aduhelm monoclonal antibody therapy approved for mild cognitive impairment in early stage of Alzheimer's has some similar adverse effects. Could it be due to similar mechanism as cancer immunotherapy with monoclonal antibodies, or could be related to complement activation? I must say I don't know. I mean, I don't know about the Alzheimer condition and what the treatment effects are. Any other questions?
Was the he had also received?
Yes, that's a good point. So she had actually received high-dose steroids earlier, which I presume was for her colitis symptoms. Now, that was a month prior. How much of that affected this is unknown, or even if it did affect anything. Now, we do know that even with known hypophosis or adrenal, insufficiency from either cause, high-dose steroids have no particular advantage over just replacement doses, unless it's just for that acute condition if they're in a crisis or so. So obviously it didn't help prevent this condition because she got it later. She actually did not feel well with those steroids back a month ago. She wanted those to be stopped. It did help her diarrhea, I think, because by the time of the colitis symptoms, which again, we didn't talk about any other adverse effects, but colitis is one of the adverse effects: rashes, skin, and GI, like I said, lung inflammation or so. So maybe it did help that, but I don't know how it affected.
Well, one of my questions, whether initial presentation was because of suppression from the
It could have. I mean, that's a good thought,
There
but
was no, initially there was no.
there were 3 ACTHs, but none of them were overtly suppressed because of the steroid. As you could see from the one post-treatment, the ACTH
Oh yeah, I mean,
was
the cortisol
definitely
was also high at that time
right.
because she was on hydrocortisone.
Exactly.
Right.
But we should have probably seen at least the ACTH suppression with the prednisone earlier, but we didn't. Yeah, there was no ACTH just that one time when she presented.
So that's one of the common problems we have in the oncology thing. They use steroids for so many of their chemo.
Right.
When this is given in combination, they often have difficulty figuring out.
Exactly. But one of the things that went with this was the MRI imaging on that same day, which showed the pituitary convexity, the headache that she had. So she did have hypophysitis symptoms. And then I thought the thyroid labs were pretty dramatic in how they were thyrotoxic initially, then primary, then secondary. Which definitely points towards the hypophysitis as the diagnosis. But yes, the point's well taken that it's really tricky because you have so many overlapping therapies and symptoms. So being vigilant is really important. Dr. Winters has a comment. You mentioned that CTLA is expressed in the pituitary. How about other endocrine tissues? Well, hypophysitis is the most common presentation with the CTLA antibodies or the immune checkpoint inhibitor therapies. So I don't know if it's expressed in your thyroid or other places. This is the one that was mentioned for sure. I would say it's definitely not expressed in your pancreatic tissue because there's no diabetes that's seen in the ipilimumab therapeutic patients. And it is probably worthwhile mentioning that the ACTH testing is likely to be normal. Yes. So if it is a recent diagnosis, your ACTH stim test may not always be helpful. I guess like any other endocrine diagnosis, this is a lot of detective work, good history taking and suspicion, and interpreting your labs in the right context. And Dr. Krishnasamy has a comment, opioids complicate the clinical picture. True, because that can also, I guess what we're really looking at here is because of the serial testing, any changes with concomitant symptoms and the MRI, like I mentioned, though MRI again is not necessary, you could have a normal pituitary and still have the diagnosis of hypophysitis. So putting everything in the context would probably lead you to the correct diagnosis.
So in the long term,
hypophysitis, barely any. But the other two, yeah. In hypogonadal patients.
Is there a statistic?
I think it's about a third.
Third?
Yeah. I've had 2 patients so far that I both have had to continue the steroids. In this particular patient, we've had her on the thyroid medication too. Right. Right on time. If you don't have any questions, thank you all for attending the talk. Appreciate your presence in person and online. Thank you.
Just saw a lady yesterday.